Welcome to Section 2 of Cardiac Embryology. In this section, we'll be discussing fetal and neonatal circulation. Let's start with this picture. We'll be using this picture to walk through all the steps of fetal circulation, so by the end of the lecture, you'll be pretty familiar with it. Right now, just focus on the umbilical vein, which is what we'll discuss first. The umbilical vein is what carries oxygenated blood from the mother to the fetus. It has a partial pressure of oxygen around 30 millimeters of mercury. This is low compared to the arterial level after birth, which is around 100 millimeters of mercury. In other words, 30 millimeters of mercury is low. However, fetal hemoglobin has such a high affinity for oxygen, so in spite of the relatively low partial pressure of oxygen in the umbilical vein, the oxygen saturation still reaches about 80%. Now, 80% oxygen saturation is still less than it would be after birth, which is around 94 to 100%. In fact, for a healthy person after birth, 80% is far too low. However, 80% is plenty of oxygen for a fetus. Anyways, the blood from the umbilical vein will then drain into the IVC through the ductus venosus. And after birth, the umbilical vein will degenerate to become the ligamentum teres hepatis, which is part of the round ligament of the liver. Now let's discuss the umbilical arteries. The umbilical arteries are two vessels that carry deoxygenated blood from the fetus to the mother. And since they're deoxygenated, they will have a low oxygen saturation, because the oxygen has already been utilized by the fetus. The umbilical arteries will actually drain the blood from the fetal internal iliac arteries. And after birth, both umbilical arteries will degenerate to become the medial umbilical ligaments. On this image, you can see the two umbilical arteries in blue. The blue signifies that they are carrying deoxygenated blood. And you can also see the internal iliac arteries right here. And it's from these arteries that the umbilical arteries branch. In addition to the vessels, there are other structures inside the umbilical cord. Let's identify those briefly. One of those structures is the allantois. The allantois in utero connects the bladder and the umbilical cord, and it will drain the fetal urine during the first trimester. And the walls of the allantois will eventually become the umbilical vein and arteries. And at some point during the first trimester, the allantois will obliterate and become the urachus. And eventually this urachus will become the median umbilical ligament. This is a cross-sectional cut of the umbilical cord, and you can see these stiff vessels are the two umbilical arteries. I've sketched this part in blue to help reinforce the fact that umbilical arteries carry deoxygenated blood. And this large flattened vessel is the umbilical vein. And I've sketched this portion in red to help reinforce the fact that it carries oxygenated blood. And this middle structure is the allantoic duct. Now this duct isn't always visualized on inspection of the cord after birth, and that's fine. After all, it normally gets obliterated. And as mentioned before, the walls of the allantois ultimately give rise to the umbilical arteries and the umbilical vein. These images are discussed in renal embryology. The left image shows the allantois branching off the cloaca. The allantois eventually obliterates into the urachus, which will connect the bladder to the umbilical cord. And if you look at the right image, you can see this more clearly. We have the bladder and the urachus. Now let's focus on the three physiologic shunts of fetal circulation. These are all shown in this image as green structures: the ductus venosus, the foramen ovale, and the ductus arteriosus. The ductus venosus carries blood from the umbilical vein directly into the inferior vena cava, and by doing this, it will bypass the liver. Now let's dive into the ductus arteriosus. So after birth, the blood will travel from the right ventricle to the pulmonary trunk, and this is arterial blood even though it doesn't carry much oxygen at all. This deoxygenated blood will enter the lungs where it can get oxygenated. This blood will then travel through the pulmonary veins to the left atrium. But this isn't what happens in fetal circulation, because in fetal circulation, the alveoli are filled with amniotic fluid, and air is not coming in. This means that there's high vascular resistance within the lungs, and this vascular resistance will inhibit the flow of blood from the pulmonary arteries, as indicated by that inhibition line. Anyways, with all this vascular resistance, fetal blood will be shunted through the ductus arteriosus instead, and that blood will flow down the descending aorta. Now let's discuss the foramen ovale. In an adult, lungs will oxygenate the blood and send it back to the left atrium through the pulmonary veins. Blood will then enter the left ventricle and then exit the left ventricle through the aorta. And from there, blood will supply the head and the body. Of course, fetal circulation is different. Since the fetal lungs aren't sending oxygenated blood to the left atrium needs to get the oxygenated blood from the mother. And so what happens is it will travel through the umbilical vein, through the ductus venosus, then to the right atrium, and then it will pass through the foramen ovale into the left atrium. And from there, it will go to the left ventricle, and then to the aorta, and to the head and the body. And blood can travel from the right atrium to the left atrium because the foramen ovale is flexible. and it will allow blood to go from the higher pressure to the area with lower pressure, which of course is from the right to the left atrium. This slide summarizes the details of fetal circulation which we described with the previous image. Blood goes from the umbilical vein to the ductus venosus, which is how blood bypasses the liver. Then it goes to the inferior vena cava, then to the right atrium, and using the foramen ovale, it will enter the left atrium. And then, as you'd expect, blood will go from the left atrium to the left ventricle, and then to the aorta, and then to the head and body. And that's how the fetus gets its oxygenated blood. Now let's think a little bit about the right ventricle. When blood happens to enter here, it will be sent to the pulmonary arteries, but instead of going to the lungs, blood will travel through the ductus arteriosus and enter the aortic arch. Now let's discuss the changes that happen after birth. This image depicts newborn or neonatal circulation. In the fetus, the alveoli were filled with amniotic fluid, but after birth, the newborn inhales atmospheric air, and this will fill the alveoli with air. This decreases the vascular resistance in the lungs. This means that blood through the pulmonary arteries will travel to the lungs more easily. Also recall from earlier in the lecture that we said oxygen saturation of the umbilical vein, and therefore the fetus, is around 80%. Well, with all of this breathing, the oxygen saturation increases more toward a normal level. In fact, this increased oxygen actually induces the closure of the ductus arteriosus to become the ligamentum arteriosum. Now that blood is traveling through the lungs, pulmonary blood will get exposed to oxygen. This oxygenated blood will then be sent back to the heart, and it does this through the pulmonary vein, and it will then enter the left atrium. And this return of blood will increase the volume and pressure of the left atrium, and this will push the foramen ovale closed. Eventually, this will seal shut, and it will be called the fossa ovalis. And after birth, the placenta, which you can see down here, is no longer providing oxygenated blood through the umbilical vein. So the umbilical vein becomes the ligamentum teres hepatis, or round ligament of the liver. Here is an anterior view of the liver, which is discussed in the gastrointestinal anatomy chapter. And you can see the ligamentum teres here, also called the ligamentum teres hepatis, which is a part of the round ligament. And again, this is a remnant of the umbilical vein. And recall that the ductus venosus branched off the umbilical vein to connect to the IVC, which would be this area. Well, that degenerates to become the ligamentum venosum. And regarding the umbilical arteries, which were down here, the segment that's inside the fetus that isn't removed with the umbilical cord at birth will eventually become the medial umbilical ligaments. This slide summarizes the details of fetal circulation, which we described with the previous image. Blood will enter the right atrium from the SVC and the IVC. The foramen ovale will become the fossa ovalis. And at this point, blood will travel from the right atrium to the right ventricle and then through the pulmonary arteries. And since the ductus arteriosus becomes the ligamentum arteriosum, then blood can go to the lungs and then travel out of the lungs through the pulmonary veins. And so the oxygenated blood will enter the left atrium and then the left ventricle and the aorta, and finally to the head and the body. Now there's just a few more things you need to know about the closing of the ductus arteriosus. Basically, breathing begins, and this will increase the oxygen level of the blood. For example, the partial pressure of oxygen increases from 30 to 100 millimeters of mercury after birth. And of course, oxygen saturation will also increase from about 80% to 94 to 100%. But the next fact to remember is that the placenta is removed, and the placenta was a source of prostaglandins. So there will be a relative decrease in the level of prostaglandins in the fetal blood, specifically prostaglandin E1 and prostaglandin E2. These two facts together, the increase in oxygen and the decrease in prostaglandin E1 and prostaglandin E2, will cause the ductus arteriosus to close, and so it will become the ligamentum arteriosum. So what does this mean clinically? The big takeaway here is that prostaglandins maintain patency of the ductus arteriosus. This can be useful in certain cases of pathologic shunts where survival depends on keeping the ductus arteriosus open. So prostaglandins can be administered to the newborns in this instance. Likewise, if the ductus arteriosus stays open and you're trying to close it, you can give the newborn indomethacin. Indomethacin is an NSAID that blocks the production of prostaglandins, so it will help it close. To finish up this video, let's talk about coarctation of the aorta. Coarctation is aortic narrowing near the ductus arteriosus, or ligamentum arteriosum, which it eventually becomes. And since this coarctation is so close to the ductus arteriosus, it's sometimes referred to as juxtaductal aortic narrowing. And there are two categories of coarctation: congenital, which is the most common and makes up 70% of the cases. The other type is acquired, which only makes up about 30% of the cases. The congenital type is associated with Turner syndrome, as well as other unclear genetic factors, which basically means that if a parent had a coarctation and it was unexplained, then their child would also have an increased risk. The next point is that there's higher pressure proximal to the coarctation. And since coarctations usually occur distal to the right and left subclavian arteries, which supply both upper extremities with oxygenated blood, then the upper extremities will have higher pressure. In other words, there will be upper extremity hypertension. Conversely, the lower extremities will experience hypotension. And the difference between the upper and lower extremities, as far as systolic blood pressure is concerned, is often greater than 10 millimeters of mercury. Another point is that there's a delayed and weak pulse in the lower extremities. This leads to the finding called brachial femoral delay. So basically, if you're looking at a newborn, you can look at blood pressures and pulses to get clues that the infant may have a coarctation. Now, in the acquired form of coarctation, there are some cardiovascular adaptations, and we'll talk more about this condition on the next slide. But in the congenital form, the heart and vasculature cannot adapt quickly enough. So what this means for the infant is congestive heart failure. Now let's talk about the acquired type. For these patients, the mechanism is unclear. However, it often occurs in patients with a bicuspid aortic valve. And just like in the congenital type, you can appreciate a brachial femoral delay. And for blood pressure, you can notice a greater than 10 millimeters of mercury difference between the upper and lower extremities. And this is similar to the congenital type, which we discussed on the previous slide. Now here's where the two types deviate. Since the cardiovascular system in an adult, or even a child that's not brand new, the cardiovascular system can adapt. So patients can develop collateral circulations. An example of a collateral circulation is retrograde flow from the posterior to the anterior intercostal arteries. This can lead to vascular engorgement, and it can also damage the ribs, which can be seen as rib notching on an X-ray. Now, this concept of rib notching and the vasculature of the intercostals in coarctation is discussed in great detail in section 1 of cardiovascular anatomy. Also, since there is lower blood flow to the lower limbs, there can be claudication of the legs, which is ischemic pain when walking and running because the muscles aren't receiving adequate oxygen. Lastly, since there's perpetually high blood pressure in the vasculature proximal to the coarctation, there can be increased pressure in the cranial arteries, and this can lead to Barry aneurysms. Now, the exact reason that increased pressure will lead to Barry aneurysms isn't perfectly clear. Now, this image demonstrates a coarctation. It usually occurs distal to the left subclavian. So we have the left subclavian here and the right subclavian over here. And the coarctation is distal to that. That means there will be increased pressure up here. And distally, there will be low blood pressure. Now let's do a question to apply what you've learned. Shortly after delivering a newborn, a physician examines contents of the umbilical cord and identifies a structure that typically has a partial pressure of oxygen around 30 millimeters of mercury in utero. Part of this structure remains in the newborn and will degenerate into what structure? Hopefully you notice that the structure described here is the umbilical vein, because we know that a normal umbilical vein will have a partial pressure of oxygen around 30. After birth, the umbilical vein will degenerate into the ligamentum teres hepatis, which is part of the round ligament of the liver. So going back to the question, part of this structure, the umbilical vein, will degenerate into what? The ligamentum teres hepatis. And that concludes this section.